Good. So this is a presentation on behalf of the team. This is the most involved surgeons, ENT and neurosurgeons from our team in Leiden. And the case I'm presenting is a recent case, and it reminded me of the image that the organizer showed on their pamphlet. It's a clavicle tumor in a 25-year-old girl, and she presented with a gradual onset of the hemiparesis on the left side. Her left arm and leg were somewhat weaker. She had pathological reflexes on examination. And then she presents with this midline tumor, which is bright on T2. It's in a craniocervical junction. It's enhancing, but not very brightly, as we saw earlier. So it's most likely going to be a chordoma, but we're going to talk a bit more in detail about that. Its midline is really filling this space with compression of the brainstem and the spinal cord. There's intradural extension with the close proximity to the vertebral artery. She has a right dominant vertebral artery. So we're going more inferiorly now. It grows in the spaces behind the musculature of the nasal and oral pharynx. It goes adjacent to the vertebral artery at the level of C1, going extradurally at that point, and then more inferiorly goes extradurally on both sides with a severe compression of the spinal cord. And it goes quite inferiorly. The bone is remodeled as consistent with a bony tumor, and both condyles are involved, but at this point there's no indication of instability. So we were asked to go through the thought process. So what are we thinking at this moment? So what's the most likely diagnosis, and do we need a biopsy first? And Paul was already addressing this earlier on, the need of biopsies and the risk of spill, and also the potential of risking your reconstruction options. What is the exact anatomical location? What will be the best treatment? And is surgery applicable? So, as you would expect, we think this is a clavicle chordoma, and the radiological images are such that we don't think a biopsy is needed. It's a craniocervical junction with the anatomical extensions as mentioned before, and best treatment is surgery, which means as safe surgery as possible, trying to remove everything or almost everything. With these tumors in other locations, they do en bloc resections, and they do like which we call an R0 with a margin. This is something that's not possible in the skull mass, right? So it's going to be an R1 or even an R2 resection, intralesional resection, however, with minimal residual. So then surgery is appropriate. Then how do we go about the surgery? With the surgery, we were thinking about the maximum spinal cord or brainstem compression, because this is giving her the symptoms. How lateral and how inferior is the tumor growing? Is there a need for fixation? And the fixation is, of course, done in prone position, and then gravity has a hold on your dural reconstruction. So this is always an issue. And as we heard before, if we do proton radiation afterwards, which is standard of care for chordomas, the fixation may interfere with that. So how did we do it in this particular case? The maximum point of compression is believed to be here at the C0, C1 level, with the spinal cord being really compressed. So we believe that it was in her interest to have that removed initially. So the first surgery should at least involve that, either with or without the other compartments, but at least involved removing this. But because it was growing so laterally as well, what we did was we went through for a transoral approach, removing the extradural tumor, removing the dents to get good access, and trying to go as lateral as possible. This was a pretty straightforward operation, although there was a lot of venous bleeding and took basically all day. We left her intubated to the ICU. Then the next day, we did a far lateral approach on the right, mobilizing the vertebral artery, resecting the intradural and extradural tumor on that side, also resecting the extradural tumor on the left side, and doing a fixation. So we do a craniocervical fixation, And what we did is in the C2, we did a special screw to allow for the proton radiation. As mentioned before, this was all discussed in advance with our radiation oncologists so that we would not jeopardize the options of proton radiation afterwards. Particles interfere with these rods. So this is a CT scan the day after surgery, showing you the rod there, the bone graft, which is essential for a good fixation, and then the rod on the other side. And these are those laminar C2 screws that are crossed, which gives you a good access. So this is a good screw for fixation, and you still have about 180 degrees access for proton radiation. This is the MRI done after surgery, showing you the fat graft, residual tumor, which is bright on T2 still with intradural growth, but a good decompression of the spinal cord. She did well. Her symptoms resolved. She went home for about a month. And then we did the third surgery. We did a transnasal endoscopic approach. We removed the tumor intradurally. We removed it from the vertebral arteries. We removed it outside of the pharyngeal spaces and did a reconstruction as normally done with fat, fasciolata, and a pedicle mucoseptal flap. And this is the post-op MRI showing almost nearly complete resection. There's this debate about this little part here, if that's a remnant or not, and we may want to go after that as well, trying to remove that. The pathology came back as a classical chordoma. So in conclusion, what we try to do with tumors like this is aim for near total resection. This is often a multi-staged and multi-approaches, so endoscopic, transoral, transnasal, and bilateral and posterior approaches. These cross screws for C2 are great because it allows you to do the fixation right away and still do the proton radiation. And one of the things we take into consideration is that if you do fixation, you have the prone position, which can cause a failure of your reconstruction because of the gravity.